Alright, so some of the feedback that I got for regarding my tests and my special tests for the shoulder and the cervical especially was the fact that I could perform the tests, but I lacked the explanation of the tests. So I thought I could make this video call to prove that I can explain the tests, although I didn't explain it initially. So I'd like to start with the NEAR test, which is used to detect subacromial pain impingement, and it's usually of the supraspinatus tendon, and the specificity is around 56% up to 58%, which means it's pretty low. That's why it's part of the cluster. And the sensitivity is around 72 to 78, which means it's good at ruling out if the impingement is negative. Then comes the Hawkins-Kennedy test. The Hawkins-Kennedy test is another test for impingement, especially for the supraspinatus tendon. So for that, I flex the shoulder to 90 degrees, I flex the elbow, and then I internally rotate the arm. This motion compresses the supraspinatus tendon, and the positive test is pain during internal rotation. The sensitivity is high, it's about 79 to 92%, but the specificity is again low, which is around 58%. That's why again it's part of the cluster. Then is the apprehension test. The apprehension test is designed the apprehension test is designed to assess the anterior glenohumeral stability, and it's usually done with the patient's arm 90 degrees in abduction, and then external rotation is applied. I apply gentle external rotation force while stabilizing the elbow. Positive test is not pain, but apprehension, the patient should feel a slight luxation or a feeling that his shoulder might dislocate. The specificity is quite high, which is around 85 to 94%, which means it's positively strong. It suggests that it's possible that it's actually unstable, and the sensitivity is roughly around 65 to 70%. Then the last is the cervical posterior anterior segmental posterior anterior glide, with which I use my fingers on the facet joints, and I posteriorly and anteriorly glide it using a spring action, and I level up each time I go. So I go from C2 to C3 to C4 to C5, or the other way back. The diagnostic accuracy is limited, but the sensitivity is about 70% and the specificity is about 60%. And this is used mainly for pain relief for patients who have a cervical spine pain area, and I would say this is rather good for pain relief with the traction included with it. It's pretty good for pain relief. So what do you have to say about this?
What I wanted to ask you about, so the first sort of those tests that you mentioned were related to what sort of cases would they be related to?
Mainly they would be related to subacromial pain syndrome, or the apprehension test would be mainly related to frozen shoulder, because it's more of a or even it could be to a slight shoulder luxation. So it could be either one of those. But yeah, mainly the NEAR test is mainly for subacromial pain syndrome.
Yeah, and could you tell me something about, like, say, a different region? Can you tell me about the cervical spine? Like you told me about the how would I call what was the test that you mentioned right beforehand about the cervical spine? Around about up and down motion.
The segmental posterior anterior glide.
Yes. What exactly is it that you're doing to say, like you say segmental, like what does that mean to you?
So you break it down as segments as C1, C2, C3, C4, C5. C1 is obviously immovable, so mainly it's C2, C3, C4 and C5 that you gently mobilize so that the patient has relief, because it could be either stiff or they could be in pain, but it's mainly for pain relief. And the cervical also has like other tests such as the ULTT, which mainly checks for nerve impingements, the ULTT 1, 2 and 3, which mainly targets the radial nerve, the median nerve and the ulnar nerve, because that's where the that's where the supply comes from.
Yes, perfect.
Alright, so I'll send you a request on this on Canvas. Alright, thank you.
Perfect.